Thank you for joining us today. I am Dr. Gina Kyler, a member of the School of Medicine and Dentistry's class of 1992. I completed my residency at the university in 1995. I am the owner of Comprehension Internal Medicine, a direct-to-patient internal medicine consulting firm that educates and empowers patients to advocate for their healthcare needs. I'm also a member of the Diversity Advisory Council, which provides leadership, guidance, and feedback to the University of Rochester on diversity and inclusion initiatives for its alumni. Today is our fourth webinar in a new series called Experience Rochester that will exemplify the university's commitment to lifelong learning. We will feature topics and speakers unique to the university, and for now, these experiences will take place virtually, and eventually, we hope you will join us for live in-person events. We have a wide range of registrants joining us for this session today, from parents, current students, to alums from as far back as the class of 1958. Before today's webinar begins, I'd like to share a few Zoom webinar tips to those new to the platform. If you would like to ask a question, please submit it through the Q&A function that is located at the bottom of the screen. Dr. Leblanc will answer questions at the end of the presentation. If you would like to view this session with closed captions, click CC on the bottom toolbar and select Turn on Subtitles. If you are having trouble viewing the webinar, you can call in and listen using the phone number that was included in your confirmation email. Now, I would like to introduce today's speaker. Dr. Natalie Leblanc is an assistant professor at the University School of Nursing in HIV prevention science. Dr. Leblanc's 17-year career spans public health, nursing, and health research in the areas of infectious disease and community health, both domestically and globally. Her primary interest is in infectious disease. Her primary interest is in identifying the ways to achieve health equity. To do so, she explores the historical, ecological, and cultural contributors that influence health and wellness. After Dr. Leblanc's presentation, Dr. Mitchell Wharton, Assistant Professor of Clinical Nursing and a Faculty Diversity Officer, will join her for a moderated conversation. They will answer as many questions as they can from the registration forms and those that will be submitted in the Q&A box. Thank you again for joining us, and I'll turn it over now to Dr. Leblanc.
Good afternoon, everyone. I was asked to speak with you about health disparities in COVID mortality and morbidity among Black and Hispanic people here in the United States. I've entitled this webinar, The Fire This Time, Inequalities in the Time of COVID. The title of this webinar is paying homage to James Baldwin. His book specifically titled The Fire Next Time. We're in his next time. Despite the title's biblical origins, he is not damning anyone, but warns that it is inevitable that for American democracy to reach its true potential, the US needs to reconcile its issues with racism. Similarly, in order for ethno-racial health disparities to be truly addressed, the legacy of exclusion and neglect of an investment in equitable public health and healthcare needs to also be addressed. So in order to contextualize the ethno-racial disparities in COVID morbidity and mortality in the US, we need to be able to situate ourselves at this moment. America is still a relatively young country, and having built its wealth by very violent and harmful means, specifically towards Black and Native Americans. Also, Jim Crow, the period that follows American slavery and also the Indian Removal Act, was a period of a very different kind of legalized oppression that decimated Black and First Nations people's self-determination towards community building. But at the same time, we have these series of federal and state housing policies and programs meant to help the American population and increase home ownership as the key to wealth building. They were implemented, however, in ways that were discriminatory and exclusionary, and mainly benefited white Americans. And so it's this period in particular is believed to have set the precedent for the inequalities that undergirds the disparities that we see today. So the ethno-racial disparities during COVID is a manifestation of long developed inequalities, and also really just sheds light on what we've known before in terms of health disparities. We frame this, the social determinants of health, the context in which people live. We also have this legacy of the USD investment in public health, and this is kind of what we're seeing in this pandemic. So the social determinants of health are conditions that contextualizes people's existence, which influences their susceptibility to disease and other adverse health outcomes, and oftentimes has more bearing on health outcomes than the biology of a person. These determinants can range from economic stability. Are people employed? Are they adequately employed? What is their income? Do they have a livable wage? To neighborhood and physical environment. Do they have housing? Do they have safe housing? We know that 45% of Blacks and 30% of Hispanics have ever reported discrimination in buying or renting a home. What is the educational level? You may have individuals here in the US with good level of education, but are highly in debt. Not only that, you have populations, do they have access to vocational training, which will help them with gaining employment? We also have a food insecurity issue in this country. 35% of Americans are obese, and that's across racial groups. And so we know that people who live in food deserts, in food swamps, have less access to healthy foods, and they're more likely to have diabetes, hypertension, all these other chronic conditions. And then social determinants of health also means, what is the social support system? Is it supporting everyone? Are people exposed to levels of discrimination? Are they exposed to levels of state-sanctioned discrimination? And lastly, we have the healthcare system. In this country, health coverage is very important to access health care. Uninsured Blacks are significantly more likely to fall into the coverage gap than whites, earning too much money for Medicaid, but not enough for tax credits. We know that Hispanics are likely to be uninsured than whites. This also has to do with provider characteristics, but also the quality of care. We know that high hospitalizations for hypertension, diabetes, and heart disease are indications of poor control and management of these diseases. And we know that this is related to being inadequately uninsured and also related to susceptibility to COVID death. So important in this pandemic is the public health and healthcare approaches to mitigate transmission. In the context of core federal public health oversight and guidance, localized efforts towards addressing the pandemic become even more important. And so here we have a tale of two cities. We have Seattle, Washington on the West Coast, New York City on the East Coast. New York City, much more denser, much more of a diverse population, have more international visitors. Early on, jurisdictions who had access to any type of test kits were asked to really focus on those individuals who just arrived from China. However, we know that in New York City, that the first cases came from Europe. In Seattle, what you had beginning of the pandemic in the United States, or experienced in the United States, is that you had these what we call EIS officers and public health officials and people from the healthcare segment collaborating very early on. And there was some quite violations of the CDC guidance around testing. They began testing cases that they suspected. And lo and behold, they were testing people who were positive for COVID, but had no history of testing, or had no history of travel, And so early on, they knew they had to craft public health messaging, which really tailored around closing of schools in order for the public to understand how important this was. They also worked with politicians to help with the closure of these schools and speaking with employers who employed many people to help people work from home and develop a plan for that. They also ensured that their homeless population who tested positive for COVID were able to self-isolate in motel rooms. When we look at New York City, we have this very esteemed public health department that's known globally, nationally and globally for its work. Also, EIS officers, very smart public health officials, However, there had been some history of tension between the mayoral administration and the public health department. And so this might have laid bare to the approach that was taken early on. You had the health department wanting to do some sentinel surveillance. However, the mayoral office at first refused. And so about a month later, they were able to do that, allowed to do that. You also had teachers' unions who had to step in and say, no, we have to close down schools. Also, I'm a native New Yorker from New York City, and our transit system is the lifeline for our city. And we also know with our homeless population, this is where they seek refuge during the winter months. However, with the subway closure for the first time in its 100-year history, where are these homeless people going? So there's something to think about in terms of how localized government, in the context of a lack of federal insight and oversight, are really having to deal with this pandemic. In consideration of the ethno-racial disparities in COVID-19 prevention, we should really think in terms of social determinants of health. Because there was an inadequate number of tests, initial testing efforts were only afforded to the affluent and again, focused on people who had recently traveled from China. And in New York City, in places like New York City, testing locations, however, were almost exclusively in predominantly white neighborhoods, meaning they were inconveniently located for people of color and people who are low income, and those people who may not have the means to go through to drive-through testing. Since then, testing has been expanded. However, as you see in the photo bottom right, that people are standing outside in the elements and standing in close proximity. So the physical distancing is not necessarily being practiced. Testing is also based on symptoms and exposure and not necessarily by job or risk. And we know that many Black and Hispanic individuals are essential workers during this time. Also, the messaging early on was to gain access to testing, you needed a gateway provider. Many people who are underinsured or uninsured may not have access to a primary provider in order to access testing. We know that the cost of testing is provided by the federal government. However, COVID care in the hospital is not. And so this may be a deterrent for people who are underinsured or not insured. They may not seek testing because they know they can't afford care. In addition, you may have people who really don't understand the importance of testing. The public health messaging around that had been kind of muddled, so they may not understand and may not go in for testing. Also, there may be some trust issues and with regards to the healthcare environment, particularly now that we're asking people to go in, but their family members cannot go in with them. So this may be a deterrent for them testing. Also, a deterrent may be that if someone is found positive that they do go and test, their employer may fire them because they're positive, or they may, because they're uninsured, underinsured, and also do not have sick paid leave, may not even stay home to make sure that they don't infect other people. When we think of barriers to prevention, we assume that everyone has access to clean water to wash their hands. We are hearing reports out of the Navajo Nation and also other First Nation peoples and reservations that people don't have running water. Similarly, in many cities across the US, we have our populations of color who look like and are experiencing what Flint, Michigan had experienced. They have water that's contaminated. So people are not able to wash their hands or wipe down their environment to keep safe. And we are hearing reports also that we're having high rates of mortality and morbidity on the Navajo Nation, but also in Flint, Michigan and other cities like that. Also, we have this issue of multi-generational housing. For many people of color, there's multi-generations that live in a home. Part of it may be fiscal, part of it is cultural. Nevertheless, you have many people living in one space. And so when we tell people to go home and self-quarantine or self-isolate, they're not able to do that. And in these homes, it's also hard to make sure to ensure that our elder population is adequately being protected in these homes. Also, we have places across the city, across the US, that are high density, these high density residential settings. And so that means people are living already in close proximity to each other which then exposes them to potential transmission. I spoke a little bit about the homeless population early on. We tell people to stay in their homes. That's assuming that they have a home. We know that there's a large proportion of the homeless population in this country that are Black and Brown people. And when we think of also prevention, when we think about these congregate facilities, we know that about a quarter of the deaths, or it's been reported that a quarter of the deaths have been in nursing homes. We know that there is transmission going on in prisons. We know that there has been correction officers across the country who have died. We know that there's active transmission going on in prisons. And so we need a better handle on that. And we also know that people of color are disproportionately represented in the incarcerated population. When we think of ethno-racial disparities in COVID infection, we know that this can manifest due to the occupation that someone's in, which may increase their exposure to the virus. We know COVID infection may be greater for workers in essential industries as well, who continue to work outside the home despite outbreaks in their communities, including some people who continue to work just because of economic circumstances. Nearly a quarter of employed Hispanic and Black workers are employed in service industry jobs. That's compared to 16% of non-Hispanic whites. Nationally, Hispanic workers constitute 53% of agricultural workers and make up 50% of the meatpacking workforce. Black workers account for 30% of licensed practical and vocational nurses. 13% of Blacks are in the meatpacking workforce. We know in a city like Chicago that your Black, Hispanic, and Asian people make up more than 70% of the city's essential workers. In New York City, more than 40% of transit workers are Black, and 60% of frontline cleaning workers are Hispanic. So simply having one essential worker in a household can put a multi-generational family at risk for COVID mortality. We also know that there is an issue with COVID outbreaks in meat and other packing industries and plants and warehouses where employers have not instituted workplace protections, like physical distancing. However, protections like benefits like adequate paid sick leave or hazard pay. And so this forces people to work even when they're sick. And we know that those without health insurance are more likely to work in service-oriented industries. Something else that I think we need to consider is the care. Pictured here are individuals who have died from COVID-19. Their ages range, but the commonality is that their symptoms manifested a month or more before their deaths. And in some cases, their symptoms were very common, the shortness of breath, the persistent to dry cough. In all these instances, and the ones that reveal itself in the news, when I go in depth, I find a commonality is that they try to engage multiple times with the healthcare system. They were told their symptoms were not severe enough. And so they finally are admitted and find that they have to be put on a ventilator quite soon. In all these cases, they died. The context of their infection could have been an indication of their vulnerability. For example, with Skylar Herbert, both of her parents were essential workers. With Deborah Gatewood, she was a phlebotomist who worked at a hospital and had asked her hospital to test her. They refused. In the case of Gary Fowler, his father had just died from COVID. And with Rana, she had gone multiple times with increasing levels of in terms of symptomology and was denied every time. So we need to really think about how are we engaging people into care? Are we dismissing people because of certain protocols, or is this another form of implicit racism or implicit bias that we see in the healthcare system? So we're at a point now where we can't unsee what we now know. It is anticipated that there is a subsequent wave of mass community spread of COVID-19 in the near future, and we may experience other global challenges as well. So there may be a next time. And so we have to think through how to better prepare ourselves for this subsequent wave, but also think about if we are ready to reimagine ourselves as a society after this pandemic. And that's the pandemic as a portal. There is a need to prioritize equity. So to address ethno-racial inequalities in COVID testing, we need to prioritize equity in COVID testing and target those communities who may be less likely to test or who have a higher susceptibility or vulnerability. And so this is just one exemplar in Philadelphia, Pennsylvania, early March. Dr. Alice Stanford, who's a pediatric doctor, decided, you know what, I have these tests. Let me go out into the community with her colleagues. And they ended up liaising with community-based organizations, with the faith-based institutions, in parking lots, and getting as many people tested as possible. To address inequalities in access to healthcare, we need to prioritize equity in healthcare and resource allocation. The proposed allocation of scarce resources may exacerbate existing morbidity and mortality in Black and Hispanic, First Nation people, and other marginalized individuals. The proposed allocation needs to consider both care plans and algorithms that are responsive to the social determinants of health and address the implicit and explicit biases which we know are inherent in healthcare. And plans should be developed by an interdisciplinary team of nurses, doctors, psychosocial professionals, and community-based institutions. Also, relatedly, there's a need to revisit messaging that advises people with symptoms to delay engagement with the healthcare system. To address the needs of the essential worker, we cannot underestimate the power of labor unions and support and protections they bring to the essential worker. An example here is the United Food and Commercial Workers International Union collaborating with Albertsons and Kroger Company. They wanted to prioritize the health of their workers by reclassifying them as temporary essential workers or temporary first responders, so that they are targeted and prioritized when it comes to testing and provision of PPE. So for this time and the next time, there is a need to support innovation in technology and in the clinical approach and even thinking about the disease. High flow nasal cannulas are non-invasive nasal prongs that sit below the nostrils and blow large volumes of warm, humidified oxygen into the nose and lung. We found that many doctors, in their own thinking across the country, decided to go with this less invasive approach than a ventilator. They also laid their patients prone. And so what you see is that they were able to have their patients who were suffering from COVID and having different levels of respiratory distress, they were able to manage these patients who then lived. Also, we have in other places of the world where they have some experience with viruses that are very contagious. The photos here are from Senegal, the right pictures are from Senegal. But first of all, they created a test for COVID, that's $1. But they also started creating these very low-tech ventilating systems. They cost about $60, and they use 3D imaging to do this. And so this type of innovation that we need to start investigating and investing in for the fire next time. It's also important that we listen to community-based organizations and people from the community on how to best manage and how to best address this pandemic. So I think I'll stop at this time. We're at the 20-minute mark, and I can talk about other topics or closing remarks a little later. So I think I will join or have Dr. Wharton join me at this time.
Good afternoon, Natalie.
Hi.
Thank you for a wonderful presentation. We have several comments and questions, so we're going to jump right in. So our first question, or our first comment, really relates back to parallels that were noticed between COVID-19 and the HIV epidemic of the 1980s and early 90s. So the question is, what lessons can be learned from either the handling or the mishandling of that epidemic, particular as it relates to people of color for this epidemic?
You know, this is a really good question, and it's somewhat embarrassing that this happened, but there was a delay in response because because we have a basic knowledge in terms of infectious disease. There is also cases happening in other countries and spreading quite rapidly. So we should have been better, in terms of responsive. But I think also what we're seeing is just, not investing enough in our public health system and really taking it seriously. I think that when you're dealing with a new virus that's unknown, no one has ever seen this before, we kind of have this paralysis, I guess this shock maybe. But I feel that people who work in infectious disease for a very long time kind of saw this coming, kind of knew, okay, there's this, we're due for a pandemic. I don't know if they would say it exactly like that, but we did have things in place this time to prevent that, even though the testing wasn't made available for a myriad of reasons that we've been told. I think it really just simply shows a de-investment in what we mean by public health and what that really means. And oftentimes we fail to have an equity lens. I know for myself, when this first started, the first thing I thought was, what does this look like for Black people? And then having had experience working and living globally in West Africa, I said, well, what does this look like for other people in other parts of the world? You're telling people to stay home, no. So those are the main similarities. It's just our response, not an appreciation of how public health works, and the de-investment in them.
Sorry. So you've approached this from a solutions oriented framework. And we have a couple of questions regarding solutions in terms of how we're thinking about this now. So you've given a couple of examples of some things that physicians or providers have been doing independently, as well as some additional things. But the question is what other potential solutions or tactics or strategies do you think are available or could be employed now while we're having this epidemic to not only guide us through the epidemic, but also to lead us to a more just society?
Well, it took us years to get here. So in terms of specifically where we are now, I don't know. I think the lack of federal leadership is driving a lot of what we're seeing in terms of different states deciding to open, and this really needed to be coordinated. I do appreciate being a New Yorker because at least there's this semblance of at least the tri-state area trying to have a united front on how to handle this. I think what we need now is to be able to listen to scientists, listen to community, listen to our essential workers. And then we also need to have an entity that's really looking at how are we reacting from a clinical perspective to the disease, because it's, every week there's something new that we're finding out. And that's important. But also how we liaise with other countries who are going through this or have gone through this. We really need to pay attention to what has worked in other places. And so the disparity that we're seeing here is not unique to the US. I mean, we have a very distinct history, but we're also seeing ethno-racial disparities show in Europe, for example, among particularly the immigrant population. And so there's certain commonalities that we know exist that's now forcing us to really reckon with. And so I feel like I'm somewhat going on, but I just want to make sure that we know that we do have the tools and we do have the people present. It's about organizing us in the right way. So I'm not sure if that answers the question.
I think so. We have a bunch of questions coming in through the chat, so I want to address some of those. One is, can you recommend a few of the best books on health disparities in the US? If not books, then particularly perhaps articles or authors?
Oh, yeah, okay. I think for a historical context, Harriet Washington's book on, I don't know the name, but her name is Harriet Washington. I'm sorry?
Medical apartheid?
Yes. I think she lays out, and it's a very difficult book to read, just because, I mean, the egregious history of just our medical system and our public health system and the exploitation of people without a voice. And so in society are not deemed important enough in society. And so to really understand how we got here, how it shapes our perception of medicine and our perception of health, and also the benefits that we reap now from the treatments that we receive have come from, in some cases, harm done to people. And so to really appreciate that, I think that's one of the books I would read. I also follow Laurie Garrett. She is a public health, I don't want to say guru, but that's her discipline. And so she's one of the ones who kind of said, listen, we need to start investing. And she was saying this like a decade ago. So those would be the first two that I would start with. And in terms of people who study disparities in public health, there's a group out of Harvard, Nancy Krieger, I follow, David Williams, I follow as well. And so yeah, I think there's definitely different institutions, I'm just naming very few, but definitely a number of institutions across the country and people who are very smart. I do follow Dr. Fauci, as long as he's still talking, I think there's some semblance of hope. And yeah.
Excellent. There have been a number of questions that have come up regarding the health disparities that have existed long before this. So COVID-19 has really cast a spotlight on these health disparities. How can this spotlight be leveraged to push these issues forward in a major and sustainable way? And what can we do to balance the scales now?
So there are a number of conversations and webinars like this that are occurring almost daily and weekly. And I think we need to pay attention to those. Just because a lot of information, and there are people thinking in this way. There are people thinking about, okay, we're in this now, but this is a time where we can really begin thinking forward and reimagining who we are as individuals, but also as a society. We have to be careful though, because some people are okay with going back to normal, whatever that was. But we're at a point where we can really think through how do we get at the systemic issues of the disparity. So I talked a lot about social determinants of health, but there are also these structural systems that we really, really need to address. And so the conversations are happening. I would say keep an eye out for the different webinars. Think about advocacy, because that is what it is right now. As I mentioned, in the webinar, that we're seeing this chipping away of labor unions and workers' rights and that kind of thing, and that's important. I mean, that's essential for the essential worker, but for people who are now disproportionately exposed. And so, again, I would say it's really advocacy. This is where, find your passion. You can have many passions, but find that, one or two and get behind that, because that's what we need right now.
I think we have time for maybe one or two more questions. So one of the things that you talked about was language and messaging. So one of the questions talks, I'll just read it here. It says that we should reach out to our Hispanic population in Spanish language, our African-American populations through lines of their work, like nursing homes and other major job descriptions. How How about sign them up for a spatial phone program so that they might get straightforward messages like weather alerts where we have this sort of type of emergency. So in the news, there's a lot of talk regarding how we're going to use apps or different forms of technology to inform people. But it's not just about the technology, it's about the messaging. So can you talk a little about messaging and how important that is to communities that have been marginalized?
Messaging is really important. I think there has been some recognition that, as contact tracing starts to ramp up, that they have to be or should be from the communities that they're engaging in. And also understand that people will come with, from the community will come with certain biases and apprehensions, and all of those are justified. And so I think being very clear and transparent early on is essential. Getting back to what you were mentioning in terms of technology. So yeah, there's this technological component, but make sure you have to make sure that it's not compromising human rights and privacy and these issues, because once people sense that, that's going to be a gross deterrent in terms of receiving and openly receiving any type of messaging. So I would just say it takes an interdisciplinary team. It also takes engagement of community. This cannot be done just in a research setting. It just can't be done in, the political office setting if you're not engaging community members from, the onset, then it's failed coming out the gate. So it's really important that everyone's at the table when it comes to how is this messaging developed. And it has to be sound, like scientifically sound. So.
Thank you. So Dr. Leblanc, thank you so much for taking the time to answer these questions. We didn't get to all of the questions. There's a healthy discussion that's happening in the chat, and I hope we can this some way offline. But I'd like to invite you to give a couple of closing remarks.
Sure. I'm not going to share the rest of the slides that I have, but I think that when we think of the health and death of people, we need to understand that Black and Brown people are not inherently diseased. There's no massive imperfections, as one physician in the early 1900s kind of labeled Black and First Nation peoples, that they're just massive imperfections, that we're not inherently diseased, okay? And I say that and I emphasize that because I have come across communities of color who, because of our messaging, because of our public health messaging about the disparities of diseases, who inherently believe that they're just sick people. And so when you use that type of messaging towards people, it then influences the behavioral change and whether it's even worth it. If I'm sick, then that's just who I am. So we first need to address that. Also, there's this legacy of harm, violence, exclusion, and inequality that underlies persistent health disparity, especially in COVID, morbidity, and mortality. And so this is just didn't happen now at this moment, but the legacy of inequality has manifested in these social determinants of health that are brought on by structures of inequality. Also, I do want to end, I guess, with a quote by Arundhati Roy. She's a novelist. She wrote a piece not too long ago around what was going on in India, but really thinking of this pandemic as a portal. And she says, historically, pandemics have forced humans to break with the past and imagine their world anew. This one is no different. So we really have to think about, what does it mean to have humility? Are we capable of empathy? Are we self-aware? Are we aware about who we are in society? Are we aware that we're operating on a global scale? This is not just me in my small town wanting, my barbershop to open and my nail salon to open. We have to think of ourselves beyond that. And so this will help us to really think about public health and healthcare reform, which is grossly needed, to be thoughtful about inclusive social and fiscal policies. And also it involves reimagining of ourselves and our society. And people are more than their biology. That's it.
Excellent. Thank you so much. I'd like to Dr. Kyler back.
Well, thank you, Dr. LeBlanc and Dr. Wharton, for that wonderful session. We are pleased to feature Drs. LeBlanc and Wharton today as a conclusion to our programming for National Nurses Week. Thank you both for your commitment to public health and to developing new and innovative ways to address health inequities among vulnerable individuals. And thank you all for joining us today. We hope you enjoyed the program, and we would like to hear your feedback. Please take a moment to share your thoughts about the session through a brief anonymous survey. The link for the survey will appear on your screen at the end of the webinar. Select Continue to get to the survey. Please also plan to join us next week on Monday, May 18th at 1 p.m. Eastern Time for our next Experienced Rochester lecture featuring Professor Rafaela Borassi and Warner students for a panel discussion, Navigating Remote Learning in Times of Disruption. Have a great afternoon, everyone, and stay well.